my big take-home points for people in general are to remember that medications are chemicals and chemicals have consequences. Reducing exposure to chemicals is always a good approach. And then the second thing that we highlighted that I've become a big advocate of even more recently is to try to really stand up for freedom of speech and against censorship and try to really understand the importance of that.
Somebody get this guy some help!
Or, put more simply,
If you need help like this guy, call your own doctor.
Just a quick follow-up. Do you see withdrawal-induced miscarriages with SSRIs? There may be women who are recognize that there is some risk, but before they come to see you, after they realize they're pregnant, they say, oh, I've got to stop taking anything that may be harmful in any way, shape, or form.
It's a very hard area to study. When you try to study miscarriage, it's a challenge just because of the way you have to set up the study. A lot of early pregnancies aren't recognized. They haven't necessarily had an ultrasound. So it's a challenging area to study. Any effect was probably offset by the chemical effect of the medications themselves. So serotonin from the get-go during the early embryonic period, serotonin is playing a crucial role in early development and early embryonic development. And so if you're altering that, it likely is linked itself to miscarriage. And so my reading of the data is that there are links to miscarriages as well as birth defects with the SSRIs. We know they're chemicals and they can affect development. Like the example I often use for people is sperm, which I'm an OBGYN, so I don't deal with this area, but I know the research shows that sperm are altered by the SSRIs. So if an SSRI can chemically alter the formation of sperm, it can certainly chemically alter the formation of a human embryo and cause effects. I think it's linked itself to miscarriage. I think that's probably the predominant thing there versus withdrawal or versus coming off. People often try to use the most severe cases or severe arguments in this area to say, look, we need women staying on these things so they won't kill themselves. And nobody wants pregnant women.
There is not good data that says that SSRIs reduce the risk of suicide. There
Right.
is just not convincing data of that. I hear that argument all the time.
Yeah.
There's no other drug outside of lithium and clozapine actually in schizophrenia that have proven reproduced evidence that they decrease the risk of suicide.
No, and I always tell people, look, nobody here wants patients killing themselves. That's not the purpose of this, or pill shaming them or guilting them. It's none of that. It's just making sure that pregnant women have the right information. And if you take that argument to its absurd extreme, you're saying that we can't provide patients with proper information. We can't actually counsel them correctly regarding risk, benefits, and alternatives, because if they heard that information, they might want to stop the medication and then kill themselves. And that's not the way to argue this. And it creates this very argument for really aggressive paternalism, which is that you're not going to tell patients about the medications they're on because you've decided that something bad could happen. And it's not clearly not the way to approach it.
It reminds me of starting out in my psychiatric training and having this fear that if I ask the patient about suicide, maybe I'll put the idea into their mind and then it'll be on me. Well, you can't do your job as a psychiatrist without openly discussing the prospect of suicide with your patients, especially the depressed ones. But I think you touched on something that is so important. And I can't remember if we talked about last time the kind of pharmaceutical playbook of swaying public opinion. It seems like if they can just convince enough of the scientific community that there's a legitimate debate on a topic, the prime historical example being whether or not smoking causes lung cancer, which we accept as an absolute 100% truth now. But for the better part of a decade, this was a scientific debate amongst our medical communities. Well, if they can produce legitimate debate, they can continue to push the narrative that promotes their financial agenda, regardless of the conclusions that the best evaluators of scientific data and research may come to. So, of course, right now, I'd say that we are still, unfortunately, as a scientific majority, in the stage of debating whether or not SSRIs have a negative impact on fetal development, as evidenced by SSRIs remaining category C in pregnancy, which indicates there is no evidence of human risk, which you and I absolutely do not agree with, but animal studies show potential risks, which it's like, come on, aren't we just glorified animals? Really? I
That's
mean,
right.
I'd
That's right.
like to think the consensus is moving towards accepting the evidence on this issue of them having significant risk in pregnancy. But, and you touched on this, we're already anticipating the next argument. Are the risks of continuing the antidepressant during pregnancy offset by the risks of untreated depression in the mother? I know you've already touched on this specific question, but do you have any other either direct comparison data or other thoughts on kind of this element of the playbook?
There's no evidence out there showing improvement of outcomes. Like, for example, with insulin and diabetes, if you take a bunch of diabetics and you look at the ones that are on their insulin, adhering to it, we'll see better outcomes. We'll see smaller babies. You'll see a better effect from that. We don't have that with the antidepressant literature. The patients on antidepressants almost across the board have worse outcomes. That's what we're seeing. And it's likely that, in large part, as I was saying, that's from chemical exposure. So we're not seeing an improvement. I generally leave that decision. I believe my patients understand themselves better than anybody and understand, and I'm just meeting them, a lot of times for the first time, and the visits are relatively short when I go over this. But the main issue is to just make the patients aware of the literature, give them proper counseling, the risks, the benefits, and alternatives, and then allow them to make that decision for themselves, what they want to do with that information, and then to try to be supportive of their decision making. I think for me, that's the most important thing. Will it be better? I mean, in an extreme example, if a woman says or feels, look, if I come off of this, I'm going to be horribly depressed. I'm going to be not functional or suicidal or other issues. And she decides, you know what, because of that, I'm going to stay on this. It's always a better outcome if the mom, for in a worst case scenario, again, and we can talk about suicide in a sec, but it's always a better outcome with a live mother. So of course that's going to be a better outcome, but that's not typical for most patients. Most patients that are on the medications, and many of them will hear the counseling and feel that, you know what, when I balance it for myself or for me, the balance is towards not being on it. I'll have other patients who feel like when they do that balance of risks and benefits and whatnot for them, they'll decide to stay on it. And then I support my patients. I don't pill shame them. I don't guilt trip them. The idea is to give them the information and then allow them to make the best decision. The problem with antidepressants in particular, though, is the issue about withdrawal versus recurrence of the illness. So for some of these studies that have been done, and for many of the patients, what they're actually going through is withdrawal from the drug. And so that then needs to get calculated into the balance. The suicide information I was going to say is that, to my understanding, there's a label on the antidepressants of increased suicidality. And again, this is not a perfect way of doing it, but if you step back and look, we've had increasing psychotropic use, increasing antidepressant use over the last several decades, and I believe we've had increasing suicide rates. So I don't think that what you had said earlier, really makes sense, that argument.
Yeah, I mean, opiates are not addictive, right? And SSRIs do not increase any risk of actual suicide, even though they carry a black box warning that they may increase the risk of suicidal thoughts. Common sense wise, it does not make sense. What I will say, because I am not just trying to push a narrative here, you are not just trying to push a narrative. SSRIs have a role. They do have a role. I think the role in our society currently in psychiatry is way overstated. And I have some very, very major critiques of how those drugs were studied, how they were approved, et cetera, et cetera. But I have a really good friend who is a neurologist that told me that that drug really probably saved his life, or that class of drugs.
Mhm.
I'm not sitting here saying that there's no reason for them, but like you mentioned, suicide rates are increasing. And tell us a little bit about suicide rates and maternal mortality in the United States and what kind of trends we've seen over the last 15 to 20 years. Because my understanding is that the psychiatric outcomes for pregnant and postpartum women in the United States are some of the worst in the developed world.
Yeah, we're not seeing this idea, whether it's in pregnancy or not, this idea that in the late 80s with the advent of Prozac, I think it was 87, Prozac was launched onto the market, that since then, because it's so effective at treating, depression and along with the SSRIs and all the other psychotropics, that because of these successful drugs we've seen this real drop off in suicide rates and real improvement over time, both in pregnancy and not in pregnancy. That's not what we're seeing. We're seeing worsening mental health across the board. And I know that's an imperfect way. An epidemiologist or a scientific researcher would look at me and say, well, there's multiple other factors going on and whatnot, and you can't just take a gross view of that. But it doesn't argue for us having a very effective drug on this. For example, like when you start using magnesium in obstetrics for women with severe preeclampsia, you lower the rates of seizure. Preeclampsia is a common illness pregnant women get, and it can lead to seizures or eclampsia if it's not addressed, if the mom doesn't get magnesium, if she doesn't get delivered. But when you use that, you see a real difference. We're not seeing that kind of difference in the population level, either in pregnancy with maternal health during pregnancy or not. We're seeing worsened outcomes.
It's kind of like if you had some infection that was making its way throughout the population and you developed a treatment for that infection or even maybe a vaccine for that infection, but the infection continued to spread and it didn't seem like the vaccine was particularly effective for a long enough period of time to stem the spread of that infection. So you can't necessarily say that it didn't work, but you don't have the evidence supporting the fact that it did work. I think the skepticism you mentioned about some of those trends that we see, yeah, it's not evidence that it doesn't work, but it certainly is not very reassuring that our treatments are working in those areas.
I absolutely agree with you that we don't. I mean, I know some of the psychiatric literature, but I don't come across, and I'm not my patient psychiatrist, but from my understanding of that psychiatric literature is that there's a lot of problems with it in terms of showing really any evidence of benefit. The STAR-D trial, I know, and others, and really trying to step back and look at it and saying, does it really look like these are making a significant improvement in mental health? I think it looks like that's not the case. I also want to touch on one other thing you had said about labeling, which is that I am working on another petition to try to get the labeling changed because there's enough evidence now, again, from the basic science and from the animal studies and now from the human studies, there's enough evidence that these medications are altering fetal brain development. I mean, it's very clear in some of the studies. They do ultrasound studies, for example, where you can look and by ultrasound, the movements or mannerisms of the fetuses are different in the SSRI group. We see that. People have likened it to akathisia or other movement things. We can see that on ultrasound. We see those effects. When you do EEGs, electroencephalograms on newborns who have been exposed to SSRIs versus not, it's got a different brain waveform pattern. We see that. We know that that's there. And MRI studies, I think they're now up to like 10 or 11 MRI studies that have shown either structural differences in brain size or functional MRI showing differences in connectivity. So we've got all of this. So for the people, the epidemiologists that want to argue, well, when we looked at autism in this study of 500,000 people and we tried to correct for whether they did get a prescription or not, and then we corrected for this and corrected for that, corrected for this, we weren't able to show a statistically significant result. That can be argued and put to the side to some extent by saying, look, we know these And I'm going to go all the way back, circle now all the way back to one of my first statements. We know serotonin plays a crucial role in brain development. We know these medications affect the serotonin system. So just by putting common sense together with those two statements, we know that the medications are altering fetal brain development. And then we see it in the animal studies, we see it in the human studies. I agree with you that it's time to actually update the labeling and warn patients about this.
I actually think that you will have an increased likelihood of being able to get that label updated because, we haven't had any real game changers medications come out in psychiatry. Well, I would say in a really long time, but we haven't had any very highly utilized meds coming out of psychiatry in a while. Therefore, all of those psychiatric patents are running out. And just for the average listener, when a patent runs out on a medication, that company no longer can exclusively sell that product. Therefore, others can get into the market and create the generic version of it. And usually it becomes a lot cheaper of a medicine. But I actually think because of that, you're going to see a new wave of psychiatric meds. They're going to be promoted as absolutely safe, as absolutely effective, state of the art game changers. And then 20, 25 years down the road, if we don't do things any differently, we'll be in the same boat that we are right now, talking about Makena, talking about Oxycontin, talking about Vioxx. And as a patient, you'll be lucky if you get a provider that understands how the system operates and is able to counsel you and come up with a collaborative decision with you on the best course of treatment.
It's so
So
difficult for patients struggling with a mental health issue. It's so challenging, or really a lot of health issues. So people are looking for a magic bullet. People are looking for an answer. But I think it's important for the public to realize that these things that we're seeing in our society again and again are often what I would call corporate rollouts. They're corporate rollouts of a product designed to maximize profit as quickly as possible and then extend it for as long as possible. It's almost like a game, a corporate
but
game.
they don't say corporate rollout at the top. They say New England Journal of Medicine, right?
Yeah,
And
that's
and and
exactly
it's
right.
it's just so difficult for the average patient. One other topic I want to touch on: when patients end up on a polypharmacy regimen, aka too many medications, it starts to get very difficult to predict all the complex chemical interactions that occur. Not only do many patients and the general public not realize, but most FDA approval trials are completely inadequate, in my opinion. Even if you exclude the data manipulation that occurs in some trials and that's ignored, the length of clinical trials is just way too short. I've heard you discuss Xanax's clinical trials being 6 weeks long, and then they take people off the drug for 6 weeks and say, no, they don't have any significant withdrawal from it. You and I'm sure you've seen it. I know that I've seen it. Xanax produces a nasty, nasty withdrawal. And actually, a retrospective study done by Harvard and Brown's Anxiety Research Project, or HARP, looking at the typical length of a benzo prescription for generalized anxiety, found that 1/3 of patients took their prescribed benzo, for more than 12 years. But the only studies we have are 6 weeks long for evaluating the effectiveness, and then another 6 weeks for evaluating what it's like to come off or withdraw from that. So you and I would guess 95 plus percent of our patients and colleagues are more curious and concerned with how a medication or treatment will impact people's lives over the next year or 5 years, not just the next 6 weeks. And there's no randomized controlled trials assessing combinations of two different drugs, including psych drugs, despite the fact that almost 40% of people on a psychiatric medication are filling prescriptions for two or more meds at the same time. So, what do you think about the lack of long-term data or the polyregimen data on so many of our medications? And how do you counsel your patients on the use of pharmaceutical chemicals long-term when there's not ample or legitimate data on long-term, both positive and negative effects?
Yeah, this is a huge problem, and it's good you're bringing this up. It's a huge problem, particularly in pregnancy, because we have trouble figuring out, even from one drug, used over a longer period of time, more than 6 weeks or whatnot. As you said, beyond the trials, we have trouble knowing what that's doing. But even with that knowledge, when you get into chemical interactions, it's it's just we haven't scratched the surface. We don't really know once you get into these polypharmacy issues. And I tend to be, well, these days a lot dealing with antidepressants in pregnancy, but my main issue is with medications in pregnancy. And we see a lot of medication use in pregnancy. So if you've got a woman that's on, let's say she's on Zoloft, and then she gets nauseous in the first trimester. So now she's put on Zofran. So now she's on Zoloft and Zofran. It might be allergy season. So she's on a medication for her allergies. She's using occasionally Tylenol. Now you've got four medications, different medications in the mix. And this is not, an absurd thing. We see this in obstetrics and we see this across the population. So what does that do? I mean, when we look at the SSRIs, just the SSRIs in particular, we can counsel patients that they increase miscarriage, birth defects, preterm birth, low birth weight, preeclampsia, bleeding. We didn't get into that today, but the SSRIs are definitely associated with bleeding. And then these long-term issues, questions about fetal development. What happens though when you add in that with something else that they're on, other medications that they're on? It's really a huge black box. We just have no idea. So that's why my counseling about this to patients is to focus on it and to understand these as chemicals that are going to have chemical effects. And that's kind of where I leave it. We don't really know, but I tell them you've got, for example, if you've got Zoloft going into the fetal brain, Zoloft's an SSRI, it's a synthetic chemical compound, it's going to have a chemical effect on the fetal serotonin system. If you're adding in Zofran now to that, you're going to have likely additive effects, multiplicative effects. We just really don't know. So our understanding, I think a lot of the public thinks that, oh, they wouldn't be using these things like this if they didn't know that they were okay. But our understanding is minuscule compared to what's actually going on out there. Patients being on these medications for years, and then again, for pregnancy, multiple medications through the pregnancy. What are the effects of an anti-nausea medication along with an antidepressant and an anti-anxiety medication, antibiotics, Tylenol, and several other things in the developing fetal brain? The true answer to that is we just don't know. We don't know. So that's why I tell my patients, the sort of take-home point I try to leave them with is that the spirit of medication use in pregnancy, we try to use the fewest amount of drugs at the lowest doses for the shortest periods of time, but while still taking care of the mother and treating her appropriately. So there's got to be a balance with those things. When I was very early in my career, I was an intern, I think at Mass General. A woman came in after, I think it was a car accident, in significant pain. And the doc on it asked me, like, can we treat her pain? And it's like, yeah, we have to treat her pain. Like, she's in pain. Like, could there be, in that scenario, could there be chemical effects on the fetus? There could be, but we've got to take appropriate care of the mother. So I think it's balancing that out.
There's in that much pain and is sending that large of a signal to her body that could be misinterpreted by the body as this is not the time to worry about a pregnancy. We got to worry about the mom, right? I see that in addiction. That's why I asked about SSRI and miscarriage, because people who abruptly come off of addictive illicit substances often will have a miscarriage if they are pregnant. So they need to be weaned off of those things. And to mention the complex interactions, Zofran works by antagonizing serotonin receptors.
Right.
So is
Yeah.
there the potential that the serotonin reuptake inhibitor is contributing to the symptom that we're now adding the Zofran on to diminish?
We don't know. We don't
Yeah.
know. We don't know in pregnancy, and we're throwing so much. I tell people when I lecture on this or when I counsel on this, never before in human history have we given so many chemicals to pregnant women and injected so many chemicals into them. We're just like, it's never been done before. And essentially it's an experiment. That's basically what it is. We're conducting an experiment on these folks themselves in pregnancy as well as their developing fetuses.
You said something with Nicole Lamberson on Medicating Normal about how our generation is so concerned about synthetic chemicals in our environment, yet we are putting more synthetic chemicals into our bodies than any other generation that's ever come before us. I thought that was such a powerful message in comparison there.
This is where the labeling is big, where the pharmaceutical industry has us thinking of medications as separate from chemicals. In fact, I see in some of the Epic charts I review, the EMRs, they've got a separate section. So a patient might be on a long list of medications, and then I'll see it'll say chemical exposures, none. And it always strikes me like, no, she's got a lot of chemical exposures during pregnancy. That's what those medications are.
But if I prescribe lithium to somebody in any dosage, I get 400 alerts in my electronic health record, 385 of them, which I've never seen or heard about.
But
But
you have
anyway,
to click through all.
luckily, yes. I mean, I have a button that I can click, not clinically relevant for all of the potential interactions. Just a quick last question. It's an impossible question to answer. It's dancing around what you've been saying for the last few minutes. And maybe it takes into account a little bit of the quantum effects that are likely happening around us at all times that we just don't really understand or have good ways to measure. So it's more of a theoretical question. Take your best shot at answering it. In terms of what we currently know in medicine, divided by the totality of things there are to know, which obviously includes things we don't even realize that we don't know, what percent of the total would you guess that we know?
I would put that as extraordinarily low.
Love it.
0.00001%. I have a lot of humility, especially because I deal with fetal development and obstetrics every day, and I'm looking at the developing babies. I mean, we just have no idea of all of the intricate interactions that are going on there to develop from sperm and egg to a full fetus, full term baby that delivers. It's minuscule in terms of the knowledge that we have. And so, because of that, it calls for this approach to try to let fetal development, to the extent that we can, go along as nature sort of worked it out over the millions of years in evolution and in development without tinkering, because we really don't know, because that answer to that calculation is so small. I would say that percentage of what we actually know is going on and what the effects of what we're doing. Yeah, I'd put that as a very low number.
You passed the Dunning-Kruger test. If you're, I like, there's a little graphic I have for the Dunning-Kruger, which essentially, when you overestimate the confidence that you have in yourself, they say that you are at the peak of Mount Stupid in the Dunning-Kruger curve, which looks like this. You start out with no knowledge, you get a little bit of knowledge, and probably like I was as a teenager, you think you know a lot more than you do. And they
Mhm.
call that the peak of Mount Stupid. But then you realize you learn all these other things that generate other questions. And you realize the more you learn, the more you realize that you don't know.
Yeah.
And then you start increasing up that curve of actually having knowledge and understanding of things. So I recommend this to my patients. I say, if you have providers, if you have people in your lives that present information with 100% certainty all the time, they're probably not humble enough. And you might want to consider seeking out somebody else who has a little bit more appreciation for the unknown and the nuance in medicine or in
Yeah.
life in general.
I always wanted to pass the Dunning-Kruger test, so I appreciate you telling me I did. I think what you said is exactly right, which is the more you learn, the more you know that you don't know. That's probably across the board. But as I said, when you're dealing with fetal development and how we all get from a single sperm and egg to where we are, it's humbling. It's humbling. And I think there's a lot we don't know. I agree.
This is at times a duty as a medical professional to have difficult conversations and adequately and accurately outline the risks versus the benefits of different treatments. It's not pill shaming. It is our duty. It is our responsibility to provide actual informed consent and to appreciate the uncertainty that exists in OB and psychiatry and life in general. So, I really appreciate your time, and it's always wonderful to talk to you. Any kind of last message that you want to promote for our listeners, viewers?
No, I think my big take-home points for people in general are to remember that medications are chemicals and chemicals have consequences. Reducing exposure to chemicals is always a good approach. And then the second thing that we highlighted that I've become a big advocate of even more recently is to try to really stand up for freedom of speech and against censorship and try to really understand the importance of that, because I think it's better for all of us and better for human progress that we have people speaking freely.
Absolutely. Well, let me know if there's any way that I can help with those submissions or anything that I can promote on your behalf. And thank you again for coming on.
Terrific. Great to join you. Thanks.
Disclaimer. This podcast is for informational purposes only. The information provided in this podcast and related materials are meant only to educate. This information is not intended as a substitute for professional medical advice. While I am a medical doctor and many of my guests have extensive medical training and experience, nothing stated in this podcast nor materials related to this podcast, including recommended websites, texts, graphics, images, or any other materials, should be treated as a substitute for professional, medical, or psychological advice, diagnosis, or treatment. All listeners should consult with a medical professional, licensed mental health provider, or other healthcare provider if seeking medical advice, diagnosis, or treatment. Or, put more simply,
If you need help like this guy, call your own doctor.
Thanks again for watching and or listening. If you're passionate about the subjects that I discuss on the channel, do me a favor and like, comment, subscribe, do whatever you can to make your voice heard, that these are problems that must be addressed in our society. If you have any questions, comments, or concerns, I want to hear them. Feel free to reach out on social media or email us at renegadepsych@gmail.com. And if you'd like to be a guest of the show, or you have a connection to somebody that you think would be a good guest, let us know. Thanks again for listening.